Hello, everyone, and welcome to the Quorum Podcast. This is where academic medicine meets remote, austere, and resource-limited areas. Welcome back to the program. This is Aebhric O'Kelly. This week, we are with Andy Bell from Australia. Andy is the Deputy Director for St. John's Ambulance in Western Australia. He is the editor for JTAM Journal, and he is an AEC, or Prolonged Field Care faculty for Ragged Edge. Andy, welcome to the program.
Hey, thanks for having me, Aebhric.
So, tell us a bit about yourself and what's keeping you busy.
Gee, what's keeping me busy? Well, I know you mentioned that I'm here in Australia, but I will have to put a caveat on that and say I'm actually a Kiwi. I hail from New Zealand originally and just find myself now in Australia. So I have been in Western Australia for the last couple of years. Prior to that, I spent a lot of time working in the outdoor industry and moving around before settling on paramedicine as a career nearly 20 odd years ago, based initially in Queensland, working for the Queensland Ambulance Service, where I spent a fair bit of time. I've also had a very heavy interest in the world of academia and research, so I've spent time working and teaching in a number of universities in Australia, done a research master's degree, and also I've published a number of papers in the research space. And then more recently, I've spent time working in the tactical space with a group called TACMed Australia, and then I've moved into the teaching faculty for AEC via Ragged Edge, and I also do some work in that space for an organisation called Blacksmiths. In the last couple of years, I found myself looking for a new challenge, and I ended up moving over to Western Australia, which for those of you looking at maps of the world, is the world's largest medical jurisdiction by size, and is effectively just a very, very large piece of not a whole lot. And that has brought to a whole heap of challenges. I came over to WA to take up the role of the head of paramedicine industrial health for an organisation called the Royal Flying Doctor Service, which is a unique service to Australia. It does have counterparts and mirrors in other places around the world, but this one was uniquely set up in Australia about 100 odd years ago to manage the very large distances of moving medical patients around a place like Australia. So traditionally that role was held by doctors. It's in the name, the Royal Flying Doctor Service, and also nurses. But in more recent times, there's been a move towards the implementation of paramedics into that space, and I was able to be a part of the implementation of that. So that was really interesting. It brought with it a huge number of challenges, mostly around resource management and geographical challenges of moving patients, and then also how to support our staff in very, very remote and austere environments. And then more recently, in just the last year or so, I've moved across to the State Ambulance Service, St. John, where I'm the Deputy Director. And here I'm now across a state service, which then again operates across a very, very large area. And all of the checks and balances that come with having to manage a staff across all of those, both geographical and resource challenges. So that's probably me in a bit of a nutshell. I very much enjoy the challenge of the remote and austere environment, and certainly enjoy the challenge of trying to manage and maximise or optimise patient management in those types of spaces. So yeah, that's me.
So you're Deputy Director of Paramedicine for St. John's, and part of that you have APRA registered paramedics working on ambulances. But part of that, isn't that there's a vast amount of industrial paramedics that kind of fall in the cracks in between? What's the difference between an industrial paramedic and an ambulance paramedic?
Yeah, it's a really good point. The term paramedic in Australia and in New Zealand is now a protected term. We are registered medical health professionals under APRA. APRA is our registering body. And as such, only those people who hold the minimum qualification plus experience are able to even use the term paramedic. So if you hold the qualification, which the minimum qualification now is a 3-year undergrad degree plus grad training post that, then you can apply to APRA for registration, and if you're successful, you can hold the title of paramedic. Now, whether or not you work for a jurisdictional ambulance service, whether or not you work for a private ambulance service, whether or not you work for an industrial site, whether or not you work for a third body like the Royal Flying Doctors, if you hold the title of paramedic, then you are entitled to use that title. The thing that you put on the front of it, like industrial paramedic, or whether or not you put ambulance paramedic, whatever, is actually more a descriptor towards the scope that you're working with and or the type of service that you're working under. So obviously an ambulance paramedic or a jurisdictional ambulance paramedic will work predominantly in an ambulance or a variation of that for a ambulance service. An industrial paramedic is more likely to work in an industrial site, something like a mine site, for example. In WA, you have a lot of offshore oil and gas type platforms and things as well. So they all fit under the moniker of industrial paramedic. The title paramedic is protected. However, the scope can vary. So that scope is then determined by the organisation and the clinical governance of that organisation that you're working for. So you could be a paramedic working for a jurisdictional ambulance service and hold a particular scope of practice, and then you could go and work for a different service, an industrial health service or something like that, and hold a different scope of practice. So that's a fundamental way to differentiate between those titles.
So, of all the different types of paramedics you have in WA, which one has the most advanced scope of practice?
That would be the critical care paramedics that are operating predominantly for St. John, for the State Ambulance Service, working both in helicopter retrieval and also on road. So the critical care paramedics hold a standard APRA registration, so they can call themselves a paramedic. They then do postgrad study, usually in a critical care postgraduate area. And then they also have to undergo an internship as well, which is a 2-year internship in order to hold the title of critical care paramedic. The term critical care paramedic is interchangeable in Australia and New Zealand with another term, intensive care paramedic. It depends sort of in which state you hear the term. That title is not protected and will differ state to state. But when you're talking about our particular critical care paramedics, you're talking about a scope of practice that includes things like the use of blood products, advanced diagnostics like point of care ultrasound, the use of blood testing at point of care like ISTAT, also an increased scope around their pharmacological interventions, and then also an increase in the types of interventions they can apply to the patient, things like your surgical airways and finger thoracostomies and things like that. So that's the I guess the title. Now, you could have a site, an industrial site, that could take on a critical care level paramedic, but it depends on whether or not they have the clinical governance to be able to enable that person to utilize that skill set. So if they don't hold for example, the drug permits or the poison permits to be able to enable them to have that extended pharmacological scope, then they can only work to the scope of the clinical governance under which they are being applied. It's a little bit of a tangled web, but we see a difference not just within individual states like Western Australia, but broadly across the different states in Australia and across into New Zealand as well.
So, a fresh graduate from a bachelor's degree paramedic program, are they able to RSI?
No. Well, they could if the service under which they operated gave them that scope. But currently in Australia, there would be no jurisdictional ambulance service. There is no jurisdictional ambulance service that would allow a standard level paramedic to RSI. But you will find, for example, that the critical care paramedics in Western Australia, the intensive care paramedics in other states, they have RSI in their scope of practice.
So your critical care paramedics, is that a master's level? You said there's an internship, but is it generally a master's level paramedic?
Yeah, so it's a postgrad is generally the initial barrier to entry. So whether or not that's a diploma, a postgrad diploma in something like critical care may be the baseline level. This differs depending on the service and state to state, but most of them or many of them do hold a master's level or above. Yeah.
One thing I'm profoundly impressed with Australia is the degree program so it's a 3-year degree program, paramedic, for bachelors. And it's the same here in Europe, of course, but you have a 4-year dual paramedic nurse program.
There are in a couple of the universities. That is one. There is also another that's a 4-year program that's an honours level program. We also have programs where it's the other way around. So a nurse with a minimum level can then apply to come in and do effectively a postgrad in paramedicine. So there are a couple of different ways of going about that. So there are some variations, yeah.
What's the relationship between the paramedic and nurse? So when I was working in the U.S., the nurses, well, they were considering themselves a higher level than a paramedic, and they kind of looked down on us, even though they couldn't intubate. Here in Europe, everyone's a bachelor's degree, including doctors, so there's a lot of equality here in Europe. What is it like with yourself?
It's more about specialization. Nurses are really, really good at nursing. And look, as we're all aware, there are 1,000 different specialties within nursing itself. So, an ICU nurse differs from a palliative care nurse. They have specializations. I think here in Australia, with the advent of our registration, with the minimum level of our qualification, what we have is paramedicine is a specialization. We are good at doing paramedicine. So that's the relationship. Paramedics shouldn't and couldn't and wouldn't walk into a hospital and tell the nurses how to do their job, and vice versa. So that's the relationship, I think, in general. There's always a little bit of, I guess, friendly rivalry around certain things, particularly around things like scope of practice. The reality is that paramedics in general have more autonomy. In fact, they do have more autonomy around their scope. There are a lot of things that paramedics can do in and around airway management, in and around the administration of drugs, in and around intravenous access, IO, etc. That is not generally open to nurses unless under different types of supervision or specialization. So there's probably a little bit of banter around that. However, again, then there are nurses that hold a series of skill sets that paramedics don't have. So, that's where we're at.
Do you have any pre-hospital nurses?
We have pre-hospital nurses in places like, generally not within ambulance services, but we do have them in places like industrial health. So if I bring it back to sort of Western Australia and we talk about the particular context here, there are many mine sites in Western Australia. Western Australia is predominantly desert. You've got thousands and thousands of kilometres of what is essentially just sand and very little else. And those mine sites can be in very, very remote, and are often in very remote places. Those sites will often have nurses working at medical aid posts within those mine sites, because you can have hundreds and sometimes up to thousands of people living on those sites in very, very, very remote conditions. So those are pre-hospital nurses. They are working in an environment that is not a hospital. They're working in an environment which is often very fluid. They will sometimes complement, say, paramedics that are working on those sites, or sometimes they will be a adjunct to, or even if there are no paramedics on those sites, they will perform that type of duty. So there is a pre-hospital nurse, I guess, model, particularly in the industrial health space.
So the obvious thing to start talking about is prolonged field care. Before we dive into that, though, I wanted to touch on academia. So it's definitely a topic is near and dear, and I think that is the future of paramedics. And I'm seeing you do that in Australia. So Talk to us. First, let's talk about JTAM. So you're the editor of the Journal of High Threat and Austere Medicine. So tell us about that.
Yeah, so JTAM, I'm one of the editors. The JTAM is a adjunct to the Australian Tactical Medical Association, and it was originally set up a number of years ago to offer a platform for the specialisation and publication of specialisation around articles that really maybe didn't fit into some of the, I guess, more mainstream health journals, etc. Uh, and then more recently, it's been broadened out again to ensure that it doesn't just become, overly niche in and around tactical, etc., but rather more to do with austere and remote medicine and health. And it's to provide a platform and a voice for those academics looking for a place to publish those specific types of articles. It's also, I think, if we just sort of circle back to academia in general, there's very much a large scale push here in Australia off the back of, again, our registration and minimum standard around education for people to move past the baseline level of a bachelor's degree into higher degrees, and often in higher degrees in research. So, we have many people currently studying PhDs here in Australia. We have now quite a number of PhD qualified paramedics, specifically PhD paramedic degrees, rather than just piggybacking off another health specialty. Also, we're seeing, an increase in the number of journals, and we're also seeing an increase in the quality of the journals. And we're seeing a massive increase in the emphasis of, legitimate evidence-based best practice, which means research. We talk about being an evidence-based profession. We talk about paramedicine being an evidence-based profession, but the reality is if we don't have our own research, then we can't be evidence-based. You can't piggyback off the back of research that's done in a non-paramedic environment like a hospital, and then take that data and say that it specifically fits to the environment in which we operate, because context matters. We all know that. And so we're seeing a massive uptick in the amount of research being done in the paramedic space, in the unscheduled healthcare space, in the pre-hospital space, whatever terminology you would like to use to define it, which then gives us a much stronger and much clearer evidence base under which we can then start to build our own, I guess, fit for purpose and higher quality education, and therefore higher quality and fit for purpose service delivery.
Yeah, I'm delighted to see the leaps and bounds that paramedics have done within academia. So when I first started decades ago, there wasn't a push or the the ability. I'm not going to say the ability. There wasn't the room for us to do this, and now this is quite common in all paramedic locations around the world, and you guys are doing it there in Australia and New Zealand.
Yeah, we've got 17 universities in Australia and New Zealand currently teaching the undergrad degree alone. That's a lot. Australia and New Zealand don't have hundreds of universities, so that's a high percentage. And of that, we have now. This was an interesting transition. When I first moved into the area of academia, it was because my previous background before I was a paramedic was I was a school teacher. So I actually have a degree in education, and it was interesting because the degrees were getting off the ground here in Australia, and there are and were a lot of really experienced and qualified paramedics back in the day, but very few who held formal education backgrounds or qualifications. So I kind of by default fell into academia because I already held those qualifications. And what happened very quickly was a recognition that academic or academia and academic paramedics are a specialization within a specialization. And so very quickly we started to see a shift towards people doing their degrees not only in, say, things like critical care or intensive care or in aeromedical retrieval, which are very much clinical specializations, but we started to see an uptick in paramedics doing degrees in higher degree research, honors degrees, master's degrees, and PhDs. So that's been a real evolution, and that's happened pretty quickly. We've seen this happen all in the space of about 10 to maybe 15 years. And that's now the wave that we're riding, and that's now that evidence-based best practice and fit for purpose is education system is what we're now seeing our current crops of paramedic cohorts coming through on. So they're really coming from a much stronger basis of fit for purpose evidence than we previously were.
And there's momentum there, so it's going to be interesting to see where this goes. So what's the 5-year dream for yourself on where academic paramedicine can go?
Oh, we've, like I said, we've got already quite a number of already completed PhD paramedics here in Australia. We've got many that are currently undergoing PhDs, masters in research, and the like. We will see a significant groundswell and continuation of that. We are seeing things like the jurisdictional ambulance services bringing in research committees to the ambulance services. Now, those research committees are formalised so that we're seeing a real shift towards ambulance services and other areas outside of jurisdictional ambulance leaning into the research space. And there is an understanding that if you want to be a legitimate player at the table, if you want to be a big kid sitting at the big kids table in the world of medicine, in the world of clinical, then you need to have your own evidence base. We talk about professionalization and professionalism, and we now hold a professional registration. But one of the defining characteristics of a true profession is the ability to have its own underpinning body of knowledge, and that's where we're moving at the moment. We're moving to our own underpinning body of knowledge, which will give us far more legitimacy in the world of professional medicine. So that's probably it. I think we'll see a continuing uptick in what that means, and that's a broadening of the role and the term paramedicine. Traditionally it was probably seen as an emergency-based type service. It was predominantly seen as a jurisdictional ambulance service. However, in Australia, for example, we now have upwards of 40% of the registered paramedics on the APRA registration are not working in a jurisdictional ambulance service. They're working in places like industrial health. We're seeing a massive shift towards community paramedics, which is a really interesting model, predominantly built around things like primary health care. And then we're also seeing a shift in the education requirements for paramedics away from that very, acute emergency-based training towards things like how do we find and increase our ability to have more accurate diagnostics at point of care. We're also looking for changes in the way that we disseminate and move our patients. So can we keep patients at home and out of EDs, which are overly crowded, and we're having significant issues with overcrowding and ramping in Australia. So we're looking for ways within the healthcare system to keep those patients out of hospital. And, the community paramedic model is and could be and will do, I think, into the future, play an extremely large part of that. So that's probably where we're heading in the next sort of 3 to 5 years, I would think. It's not even where we are. We are definitely heading that direction right now.
I like that you mentioned pushing the body of knowledge of medicine, and your journal, the JTAM journal that you produce, is doing that, and you are making a difference.
Yeah. Well, I think that's the thing with knowledge, isn't it? It's a rising tide lifts all ships, and so we need to adhere to that. And one of the things I think that the pre-hospital space in paramedicine has traditionally been a little bit I don't know, has found itself sort of out there on its own, kind of doing its own thing because of the context in which we operate. But we are very much a cog in a much bigger machine. And the better that we can integrate into the broader world of medicine, then the better it is going to be for us as a profession, and the better it's going to be for our patients, because they're going to get a better quality of care through the continuum of their time as a patient. And that's really something that we're drilling into at the moment, is not just getting paramedics and people that are operating at that point of care in the pre-hospital space, is not just to think about, okay, here's your patient and you're managing them in the immediate short term, but rather how can you optimize their management so that, okay, you may only have them for an hour, but if we manage that septic patient, for example, better, then we could take their time in hospital from a day, from weeks down to days maybe, because we've given them a much better quality of care prior to them being moved to definitive care in the hospital. So that's the mindset shift that we really need people in the pre-hospital space to start taking.
So let's talk about prolonged field care. So you live and work in Western Australia, and I've been there. I've jumped into Western Australia as a Green Beret. I spent several months there in Swanbourne,
Yep.
and I can say it is one of the most remote and desolate places I've ever operated as a civilian or as a SF guy,
Yeah.
and it's incredible that the amount of distance the tyranny of distance that you have. And so I understand why you are a faculty with Ragged Edge Solutions, that you are pushing austere emergency care in Australia, and the need for prolonged field care is profound. And I'm not pretentious to say that we're teaching you prolonged field care, because you probably have done prolonged. You probably just call it medicine,
Yeah.
and it's in insanely remote locations. But so tell us about the prolonged care that you are currently doing. Tell us about why you joined Ragged Edge Solutions, and why you are teaching AEC.
Yeah, we call it business as usual, because I think maybe if I give it a little bit of a case study just to give it some context for people that are listening, you know, you could have a patient have an incident on one of these remote industrial mine sites out deep in the Pilbara Desert, for example. Now, at that point of injury, they're going to be managed at the immediate time by probably someone else in their team who may be nothing more than a first aider who's done a basic first aid course and is carrying like a very fundamental IFAC. So let's say we've got a patient and he's gone and stuck his leg into the auger of a drilling machine. So he's now got an extensive injury to the lower leg, and with excessive and substantial bleeding. The point of care of his team are just, they're drillers. They're not medics. They're not tactical. They're not in any way else trained. So they apply the appropriate interventions, hopefully, to stem a life-threatening hemorrhage like a bleed, maybe the use of a peripheral arterial tourniquet or wound packing, something like the like. Now, that patient will now be either have to be moved from the drill site, which could still be an hour or more from the actual mine site, to the medic on site. And we talked about industrial medics or paramedics before. They may be met en route in the desert, or they may be brought to the site. Some of these sites are nothing more than a collection of shipping containers in the middle of the desert. And I mean that, literally a collection of shipping containers. That medic then is now going to take over, a handover from that drilling crew, and is now going to take over the care of that patient. And that patient is going to be managed at a higher level of care, up to the level of that particular paramedic and the scope that they have available to them. And that paramedic's going to make the determination that this person needs to be moved from that site. If it depends what, and we can equate this to some tactical spaces. If this occurs in the evening in a very remote site, there's no way to get that patient out, because you can't drive through the desert in the night because you get lost, and you can't land a plane on the landing strips in some of these places because they're just literally dirt strips in the middle of the desert. There's no illumination. You have things like camels, etc. So you can't land a plane. Someone like the Royal Flying Doctor Service will not come. So you may be now managing that patient overnight. At which point, let's say that has occurred, and you've stabilised the patient overnight, managing both their pain and their hemodynamics. You manage to get a plane in or a helicopter in the morning, and that patient is now handed over and loaded maybe into a PC-12 for the RFDS, for example, or a helicopter, and then moved to a smaller centre, somewhere like Port Hedland, which is a town but has what we would call a hospital, but that hospital is very much does not have the ability to manage any kind of significant major trauma. That patient can't be flown directly to Perth because the plane won't fly that far. These are massive distances. So the patient will be moved to somewhere like Port Hedland, where they'll be handed over to something like the district hospital, where they'll now be managed at that scope of practice by the clinicians there, usually a doctor and some nurses. and then they'll be packaged again for another flight, this time probably by RFDS again, but possibly in a bigger plane, which covers more distance, to then move them from that site all the way down to Perth, thousands of kilometres away, where they'll be handed off to St. John, to the ambulance service, where there'll be another clinical handover, where that patient will then be managed by road, because where RFDS lands is you can't land a plane on the hospitals. So they will then have to be moved by road to one of the few state trauma hospitals that are actually located in Perth, where there'll be another handover to the ED staff. The ED staff will then manage that patient in ED, and then will probably transfer that patient to whatever specialisation is required, surgery, etc., orthopedics for management. So that could take that patient who's put his leg into an auger on a mine site may not be seen on that surgeon's table for 12 hours, 18 hours, 24 hours. It's entirely possible. And so we're doing PFC just as a matter of fact, because that's just the way it has to work. Same thing, if you have a patient that's acutely unwell in one of these offshore oil and gas platforms, then the multiple legs and handovers required through series of different types of clinical care and scope, again, could take days before that patient's seen in definitive care in Perth. So, PFC, just business as usual for us. What that means, obviously, is, we have to think about how do we optimize the management of these patients through all of these different levels of care. We have to think about what is the differences in the scopes of practice, and how can we ensure that we minimize, problems between those different scopes. And then we have to think about what is going to be the best way to get the patient to the level of care that they require. And that requires a significant amount of communication between often 2, 3, or 4 different organizations to ensure that that's going to occur. So I guess that brings my attention to things like PFC, and when I had the opportunity to go and do a course with Sean and the guys, and Bill and the guys from AEC, I did that over in New Zealand, which I thoroughly enjoyed, and then was offered an opportunity to do the teaching cadre course. I jumped at it. And then from there, there's been opportunity to teach some courses in both New Zealand and Australia. And then more recently, I've spent time in America at SOMA teaching an AEC instructor development course for that particular organisation as well. All of those things are really designed for me around, like, how do we make the most of what we've got, and how do we optimise the care for the patient, so that we give them the best chance for the best recovery, not just survival, but the best chance for the best chance of recovery. If it means, and I know recently, I actually, I'll have to admit, Aebhric, and I think I even told you this, I stole your SAFE acronym for the de-escalation of tourniquets, which I think is a very clear and very succinct acronym, which is why I stole it, where I presented at the Western Australia State Trauma Conference, along with a guy called Matt Pepper, who will be well known to, I think, some of your listeners. He's the founding president of APRA Australia, and is now the current, he's now working in the role as paramedic lead at Royal Flying Doctors. We presented on the de-escalation and conversion of tourniquets, because in a state like Western Australia, yes, it's important that we save someone's life and prevent them from bleeding out from a catastrophic bleed with the use of something like a peripheral arterial tourniquet. But because of the tyranny of distance, because of the nature of time, and the fact that this patient may then have this thing on for extended periods, then we really need our clinicians to be thinking about what is the optimization of the placing for that particular tourniquet. And, if I use the case study I just used, if that guy's lower injury was a lower leg injury below the knee, but their initial tourniquet was placed high, tight, and horizontal because it was placed by a first aider on an industrial site. And that's an entirely appropriate thing to do, because they just wanted to stop the guy from bleeding to death. it's important that as that patient transfers through the different levels of care, that wound is addressed again on multiple occasions, and if it is appropriate to do so, that tourniquet is de-escalated and possibly even converted, in order to ensure that we save the maximum amount of tissue, and then obviously improve that patient's long-term quality of life. So yeah, it just makes sense in our environment.
Wow. So in Ukraine, somebody gets injured and they can get to a stabilization point faster than most of the massive injuries you're seeing in Western Australia. And you said that Royal Flying Doctor Service can't medevac some patients without having to stop and refuel. So you got to stop, put them in a local clinic overnight, refuel, start again, and then get to Perth.
Yeah, and in fact, so the Royal Flying Doctor Service utilises two main platforms: the PC-12 and the Pilatus PC-12 and Pilatus PC-24. The 12 is the workhorse; it's the one that does the majority of the work, because it can be put down in a really diverse range of landing strips. So they can put it down in a lot of places. You can't put the 24 down in a lot of these places because it just isn't able to handle the terrain. And so what you will often see is piggybacking. So you may see a PC-12 retrieve a patient from a remote site back to a bigger centre like Port Hedland or Broome or places like that, where it will be met by a PC-24. If the patient is time critical, then that 24 may fly immediately with just one patient. But because we're talking about such a big state, and we're talking about the fact that, you know, there are more than one patient occurring. Now, some of them are not trauma patients. We're talking about obstetric patients. We're talking about just general medical patients, etc. It might be that, so the PC-24 will take 3 patients on stretchers. So they will often stack patients. So you'll have, say, multiple PC-12s arriving at a centre that then will stack patients into the 24, which may mean then that there's a delay waiting for another patient while another PC-12 arrives from another site, before that 24 flies back to Perth, if that's the best way to maximise the resources available. So this is, again, what I mentioned sort of at the start of this conversation, which is, you know, we're dealing with an environment, both from distance and resources, that means that there's a huge amount of communication required. And more often than not, the management of these patients is being done in an environment which would be definitely considered suboptimal in other jurisdictions. But because of the nature of the context in which we operate, it's just the way it has to be. So we're really looking at, like, how do we make that the best based on the context in which we operate.
It sounds to me like you need a SOST, a special operations surgical team, to get on a C-130, fly over whoever's injured, drop them out, and get down there and do the surgery.
Do you know what? I would suggest that the system that is in place is probably as good as you're going to get. You could possibly do that, but the problem with that is you're now dealing with large amounts of fiscal costs and things as well. And it has, in fact, occurred where certain specialist doctors have and are flown to particular sites. There was a case in Australia recently, I'm sure many people listening to this podcast would be aware of it, which was in Tasmania, where a whitewater rafter was entrapped in a river. Now, paramedics were special operations paramedics were sent to that scene to stabilise that patient and kept that patient alive for an extended number of hours, but were unable to free him. And that gave time for a specialist doctor to be brought in, and eventually, due to the nature of the patient's deterioration and the environment in which they were operating, he amputated that patient's leg on site in the river, and then they had that patient transported to hospital, and that patient survived in Tasmania. So, there is grounds for that to occur, but it certainly is not the norm. The norm is that we, have paramedic sites, and working in these industrial sites who are able to manage these patients. And then we have a series of different levels of progression of care, which manage the large majority of patients in an appropriate manner. Now, we're not talking, this is not happening, daily. It's not like the Ukraine situation, where you're probably having quite a large number of patients occurring daily. So, like I said, a lot of these patients will be less time critical. They may be a patient with some respiratory distress. They may be a non-acute or time critical cardiac case that just needs to be moved off site and just needs stabilization. And that's where things like, the use of thrombolytics can be done in the district level, so they're not having to come all the way back to Perth to be thrombolized. So you've got all of these differing levels, and then things like obstetrics, the Royal Flying Doctors Service. The nurses on that service, in the majority, are also dual qualified midwives. So more often than not, if there's an obstetric requirement, then they already have the specialist in situ on the plane to be able to manage that particular type of patient and case.
Wow.
So,
Wow. So
yeah, it's a unique beast.
yeah, that's incredible. So let's talk about prolonged field care and Western Australia. And you're teaching the AEC course there in Perth. Is that right?
We haven't run a particular that course here. We've run it in Brisbane, and the reason we ran it in Brisbane is because we correlated it with the APRA conference. So with the Tactical Medical Association conference, so that's where it's been run. There is obviously opportunity for that to increase and diversify, and there's plans afoot for, I think, the course to be run again in conjunction with the APRA conference again. Like I said, it's also been run in New Zealand in a number of cases. In New Zealand, it's been used quite extensively to upskill groups from the Pacific Island response. So places like Samoa and Fiji, where they are dealing and often deal with things like tropical cyclones and tsunamis in an already very resource poor environment. And so they are operating in a PFC environment, almost BAU as well. And so they're being brought up to speed with how to manage when there's an exacerbation of their standard level of care, because of the nature of something like a less likely to be something like a tactical issue, more likely to be something like a weather event that's going to lead to the reduction in resources and the extension of time leading to a PFC situation.
So it sounds to me like your paramedics, your pre-hospital staff in WA is already doing this. So is there a need to teach AEC? Where is the educational deficiency for the paramedics you're seeing in your area?
So to me, PFC is more about that point of contact, that point of injury care. So specifically, we've talked and touched on that industrial paramedic, industrial sites. Like I said, those sites are extremely remote, and in some cases, you can be talking. I was on a site last year that was 10 hours drive, most of which was by four-wheel drive before you got to the next town. And we're talking about, again, a site that was really nothing more than a collection of shipping containers. So if you don't have the ability to fly someone out because of a weather event, etc., then you may be going out by road, or it may be that you can't get them out overnight, for example. Those patients need to be managed in situ, and to me, that's the real, I guess, advantage of having someone who thinks PFC. And I think when you're talking about prolonged field care, I really think not just around the specifics of the actual skill set, but it's a mindset. It's a mindset change. It's like, because most paramedics, particularly ones that work in a metro setting, really only think either in minutes or perhaps in like hours at max. And that changes and frames the way you go about your care, because you know that you only have to do something for 15, 20 minutes, and then you're going to be handing them off to something else. And so when you have someone who goes, I'm going to have this patient now on an offshore oil and gas platform for a minimum of 6 hours, because we can't get any kind of help out here for at least that long, plus turnaround, then that reframes and changes the way you go about how I'm going to think about managing this patient. It might change the way you go about setting up for things like nursing cares, because predominantly and certainly historically in the world of pre-hospital and paramedicine, nursing cares have not been given a huge amount of bandwidth. It's been very much around that acute management of high acuity emergency work. But if you have a patient that's going to be in situ for hours, if not days, then that move towards the nursing cares and the management of that patient is absolutely critical. The other one is obviously the move into tactical space in and around the use of and training of the military and or special operations teams. It certainly has a place in things like TRGs or tactical response groups or special operations response groups in the police, etc. Predominantly, if you have a special response group working in rural or remote Australia, whether or not it's Western Australia or Queensland or the like, and that team is now held down because of a tactical response, and they're unable to move people back out of the hot zone, then they're going to have to manage that patient within that zone because, if you can't get the care in and you can't get the patient out, then it now falls to you to manage that patient, and however long that might be. So there's another environment and certainly another area that we've been seeing an uptake of this type of training. So, yeah.
So for these guys who are treating a casualty for long periods of time, are you going through the Hitman or the sheep vomit or the ravines, or what system are you using for your ambulance, your St. John's ambulance paramedics?
So see, this is the thing. Again, when we talk about the case study that I used before, that patient will have gone through 5, 6, 7 different clinical handovers jurisdictions, from an industrial site, from St. John jurisdictional ambulance, from the Royal Flying Doctors, from district health and country health, through to metro health and the hospitals. So if you utilize something like sheep vomit, etc., then that's not going to be recognized, for example, by the hospital because they don't see it, they won't have seen it. So we tend to generalize and utilize things like IMIST and IMIST AMBO type handovers, for example, because that is the more widely recognized format. What it means then is it falls to the clinician to be able to ensure that their handovers are clear enough and succinct enough and accurate enough that they can be translated into another system or another way of notation so that nothing is missed. Now, is that happening? I don't think it's being done as well as it could be. Would I like to see standardization? Yeah, I'd love to. Will we see that? I don't think so, not in the immediate short term, because I think there's still a series of other things that play outside of the clinical space. Obviously, government, politics, etc. And so we see a disconnect in and around things like standardization of patient care records. So that's definitely an area that needs to be tidied up and tightened up.
So, Andy Bell, my final question for you is this. What advice do you have for the doctor, the new nurse, the new paramedic who is just starting out on their career in austere medicine?
Be really, really good at the basics, because you can't free up operational bandwidth to think about anything more complex when your mind is caught up just doing the fundamentals. So the best clinicians are not the people who know the most, they're the people who do the basics the best. Get really good at those basics, then keep an open and flexible mindset to think about what it is you're going to need to move the patient forward, and then always be constantly and continually patient focused. It should be patient centered. Am I doing the best thing for my patient in the immediate term, in the short term, in the moderate to long term, and then to the long term? And what can I do in that patient with my patient care to optimize their long term outcomes in all of those different stages of their patient journey? That would probably be it, I think. Pretty
That's
basic,
good
really.
advice. That's good advice. Well, it's been fantastic to hear about what you're doing in austere medicine and in Western Australia. And it's been really lovely to have you here on the podcast this morning.
Oh, thanks very much, Aebhric. I really appreciate it, and certainly, we're learning every day, and we're getting better at things, and certainly, like all other systems, we're far from perfect, but we're certainly working on it. So, thank you very much, and also it's great to see the impact that Corom and yourself and others in this space are having, spreading the word around PFC around the world. So, thank you.
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at quorum.edu.mt.